Welcome to Go Home and Go Big, Strategies for Scaling Hospital-at-Home Programs, a webinar sponsored by the Hospital-at-Home Users Group and presented in partnership with the American Academy of Home Care Medicine. Next slide. We'd also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. Next slide, please. Before we get started, just a few housekeeping details. Please submit your questions via the Q&A option as opposed to the chat. That will help us keep track of them more easily. Due to the large audience for today's webinar, we have placed everyone on mute. And if you are having any technical issues, please send me a message in the Zoom chat feature or at my email address, jbielenson@aboutscp.com. And just so folks know, slides and the webinar will be available afterwards on our Technical Assistance Center and on the events page of hahusersgroup.org. Next slide. So just a word about the Users Group, which is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and quality policies necessary to build the field and to spread this hopeful, person-centered model of care throughout the United States and North America. Please visit our website at the URL noted there, and be sure to check out our TA Center for helpful HAH program resources and tools, as well as our recently refreshed Research Center. You can also follow us on Twitter or X. Next slide. This is the 23rd Hospital Home Users Group webinar that we're offering. There are many topics, a broad range of topics that are available on the website. Find a topic you've been thinking about or working on and take a look. And again, check out the events page on hahusersgroup.org. Next slide. Finally, a team of researchers at Mount Sinai is looking to interview hospital-at-home program leaders for their input on the caregiver experience and their expertise on caregiving issues. To participate, simply scan the QR code here on the slide, or you can contact us and the study at info@hahusersgroup.org. And I'll give folks just a second there if they want to take a photo of the QR code. And the next slide. It's now my pleasure to introduce our moderator for today's webinar, Dr. Trini Trong, who is a hospitalist and associate professor of medicine at the Icahn School of Medicine at Mount Sinai. Dr. Trong is passionate about home-based clinical delivery models that deliver high-quality, patient-centered care to patients in the comfort of their homes throughout their entire medical journey. As the Chief Medical Officer of Mount Sinai at Home, one of the nation's largest hospital-at-home programs, Dr. Trong creates the vision for and implements strategies to operationalize, integrate, and grow the clinical services within Mount Sinai at Home, which includes hospital-home services, rehabilitation at home, palliative care at home, and other affiliated offerings. So please take it away, Dr. Trong. Next slide.
Oh, thank you, John, and thank you for inviting me to moderate this session. It is really a pleasure of mine to moderate this, I believe, very important session on hospital-at-home scaling. Hospital-at-home has gone really from an academic experiment to clinical model that many hospitals and health systems, including ours at Mount Sinai Health System, rely on to deliver the right care, the right time, and right place to the right patient in the right space, and really to offset the need for increased need for inpatient beds. You and many others have demonstrated that this model is safe, effective. Patients love it. We, the care teams, love it, and it potentially addresses health equity and cost saving as well. So essentially, this model of care addresses the quintuple aims in healthcare. Hospital-at-home adoption has increased across the nation as a result of the COVID-19 pandemic. However, it is not yet a major clinical model for inpatient care. That is to say, hospital-at-home adoption has moved from the innovator space to the early adopter space, but has yet to enter mainstream. To cement hospital at home as a serious and major player within the inpatient care space, we need to increase our footprint. Short and simple as that. Currently, we collectively contribute to a very small share of inpatient care, probably less than 1% of all inpatient care. To truly get the government and health systems, our health system included, more attention and more long-term attention to this model, we need to demonstrate significant scalability. I believe that we need to increase our footprint to a lot more, perhaps at least 10% of where we are right now. Now, it is easy to say we need to scale, but doing that is very, very hard. Many of us do live and breathe this every single day. There are significant challenges such as payment or cost, culture, infrastructure, and processes. The majority of these barriers are shared amongst all of our programs, but luckily for us, there are health systems that have been successful at scaling and doing it at impressive rates. So I'm so glad that today we get to hear from some of these successful programs. I'm going to introduce our 3 distinguished panelists to lead the discussions today. Dr. Daniel Davis served in multiple medical leadership roles within Atrium Health. As Medical Director of Continuing Health, Dan has medical oversight responsibility for multiple home and community-based programs, such as hospital at home, mobile integrated health, transition services, and home health. As Medical Director of Atrium Health Primary Care Connect program, Dan spearheaded the development and implementation of a virtual nursing care coordination program across the Atrium Health primary care footprint in North and South Carolina, Georgia, and Alabama. Primary Care Connect has touched the lives of almost 13,000 patients since the inception in 2021. In his role as Medical Director of Internal Medicine, Dan has responsibility for 140 internal medicine physicians and APPs to provide care for over 175,000 patients. Now, amazingly, Dan still makes time to continue practice as an internist in Charlotte, North Carolina. Dan received his bachelor's degree from the University of Kentucky, his MD from Wake Forest University School of Medicine. He then completed his internship and residency in internal medicine at Wright-Patterson Air Force Medical Center in Ohio. After leaving Air Force, Dan was in private practice for several years before joining Atrium Health in 2015. Dan enjoys spending time with his wife, Shannon, in both the mountains and the coast of North Carolina, and is extremely proud of his 3 adult children. Dan today will discuss hospital-at-home scaling across many hospitals within the health system. Next, I want to introduce Ms. Karen Falkenberg. Karen is an experienced nurse leader with a passion for team building, innovation, and patient-centered care. Karen is the Executive Director of Nursing and Patient Services at MGB Health at Home. Karen partners closely with amazing team of dedicated professionals fully committed to changing the landscape of healthcare. As Executive Director of Nursing and Patient Services, Karen oversees the clinical operations and build of several service lines in partnership with her team. Bringing excellence in patient care to home through the development of innovative integrated paramedicine and nursing model is a major concentration for her team. Karen is currently pursuing her DNP in executive nursing leadership at MGH Institute of Healthcare Professionals, and she will be graduating at the end of this year. She is also an active member of Organization of Nurse Leaders and Emergency Nurses Association. And Karen will discuss scaling in the context of managing census variability. So demand and variability of demand and supply of staff, demand of hospital at home beds, and variability in staff and staffing. Next is Dr. Michael Nassif. He is a board-certified cardiologist with St. Luke's Cardiovascular Consultants and is on staff at St. Luke's Mid-America Health Institute in Kansas, Missouri. Michael received his medical degree from the University of Iowa. He completed his residency, chief residency, cardiology, and heart transplant fellowships at Barnes-Jewish Hospital, Washington University School of Medicine. During his training, he also completed a cardiovascular outcomes research fellowship and master's degree in clinic investigation at St. Luke's Mid-America Health Institute at the University of Missouri, Kansas City. Michael's research interests focus on the intersection between diabetes and cardiovascular disease with a specific focus on heart failure. We do have a lot of heart failure in hospital at home, so that's good. Michael will be discussing scaling in the context of culture change in the emergency department. I am so thrilled to have these three panelists to share their experiences and learning from scaling their hospital at home services. Next.
Thank you, Trini. Again, I'm Dan Davis, and I'm here to discuss the Atrium Health Hospital at Home scaling experience over the last several years. Atrium is a large integrated healthcare system that is headquartered in Charlotte, North Carolina, and is now part of a larger organization known as Advocate Health that spans from Milwaukee, Wisconsin through Chicago, and then down into the Southeast into North Carolina, South Carolina, Georgia, and Alabama. On the next slide, you'll see a little bit about our experience with hospital home at Atrium. Our initial hospital home program was started in March of 2010 in response to the COVID-19 pandemic and the subsequent inpatient capacity crisis. We were able to stand up our hospital home program over the course of 10 days from the first meeting to the first patient being seen. We were able to do that because we had an existing infrastructure that of community paramedics through our mobile integrated health program that was supporting other strategies within our systems, and specifically our transition program. We were able to leverage those existing programs to be able to start delivering care in that relatively rapid period of time. We were able to build and scale to Mecklenburg County, which is the county that Charlotte is in, and to 10 surrounding counties over the coming months. Of course, the census did wax and wane with the pandemic. We actually had a short period of time when the program was actually closed for a few weeks prior to a surge in mid-2020. Eventually, we had permanently assigned staff and expansion to non-COVID diagnoses starting in September of 2020. We implemented the CMS acute care at home waiver in our first 3 facilities in March of 2021, with expansion to all 10 of our facilities in the greater Charlotte market over the next 6 months. Our census did wax and wane over the next 3 years or 2.5 years. And ultimately, we were able to get to the point where we've been able to expand and now have a budgeted census of 60 that began in October of 2023. And we'll talk a little bit about that journey. On the next slide, you'll see this is actually our census, our total monthly unique patients starting in January 2021. So we took out 2020 because of the large numbers that we had when COVID first started. And then in January 2021, when the census really was primarily driven by COVID, but also starting to take care of other diagnoses. Totally, as you can see on the left, we've taken care of over 9,400 patients since March of 2020. You'll see, though, however, that our census remained relatively flat from sort of mid-2021 through mid or May of 2023. Slow increase in census. At that time, we were running a census in the sort of 25 to 30 range daily, and a monthly census in the 175 to 200 range. What we did in mid 2023 was we actually developed a more comprehensive program for care in the home. And we made hospital at home, we intentionally placed hospital at home in this same strategy with our transition clinic, pulled in mobile integrated health leadership, as well as our home health leadership, and other primary care strategies to have a more cohesive strategy towards how are we going to grow hospital home, how are we going to leverage these resources. And as you can see, subsequently, we were able to start to increase our census over the coming months to December, when we had a total number of unique patient counts of 318, and ended the month in December with an average daily census in the high 40s. On the next slide, it actually divides this census growth out by our facilities. And this is 2023 data. We do track our average daily census and our total monthly volumes by facility, and you can see that we did grow, and really the upturn started in May of 2023. And we'll talk a little bit about some of the strategies that we did to do that. The next slide shows our outcomes to date. Again, mentioned that we've taken care of a total of over 9,400 unique patients since inception in March of 2020. We have saved a total of greater than 33,000 brick and mortar bed days for our patients. Average length of stay is around 4.6 days. From a quality perspective, our readmissions ODE is 0.8, which is better than our brick and mortar facilities. We've had a mortality rate of less than 1%, and our return to brick and mortar escalation rate is 5% currently. We do all this with very good patient experience. Overall, both our overall rating and our likelihood to recommend is better than our brick and mortar facilities. Again, not that our brick and mortar facilities don't do a good job and patients aren't happy with it, they're just happier to be at home. So to talk a little bit about how we have grown the program and some of the key scaling factors and priorities, listed some things on the next slide. So for one, we've had ongoing acute care facility capacity constraints. So we've been able to maintain our program over the last 4 years, despite the waning of COVID, because we have a rapidly growing population in the greater Charlotte market, and we don't have the ability to continue to build brick and mortar facilities to keep up with our population growth. So our acute care facilities are under significant capacity constraints. And so we have that as a primary driving factor for us to, one, first maintain our hospital at home program, but also to drive the growth of our hospital at home program. Over the last 3 years, we've also maintained our necessary infrastructure by utilizing that infrastructure through other care at home strategies, such as our transition clinics, and other programs to be able to utilize primarily our MIH program, which is our community paramedicine program, which is the boots on the ground members of our team in our hospital at home program. We've also been able to utilize providers when census has varied in a flexible model where we have a dedicated provider staff. So we have dedicated hospitalists, both physicians and APPs, but we also have the ability to flex and use some of our brick and mortar hospitalists when census goes down in a moonlighting fashion. And that's allowed us to be able to go up and down with our census without having to have fully dedicated staff to reach certain census goals. Again, our financial model is based on capacity creation as well as cost savings. We just simply don't have enough beds to be able to take care of all the inpatients that we have. We then also developed an incremental growth plan this year when I mentioned that we had approved to have a budgeted census of 60 starting in October, but we did that in an incremental way. So we developed an incremental plan by which to grow both the provider staff, our nursing support staff, our mobile integrated health staff, and all the ancillary staff that we need to be able to maintain that census. One of the things that we've noticed too, though, is that part of the waxing and waning of our census has to do with the culture within our facilities. We have certain facilities that are incredibly engaged in the hospital at home program and do refer patients regularly. And then we have many facilities where we lag in engagement of the providers. So what we developed was some facility-specific internal marketing to target the facilities that have the greatest capacity crisis, which actually were not always the facilities that were the most engaged, but to target the facilities that had the greatest capacity crisis, but also to try to dig into what are the rate limiting steps, what is the culture that is difficult to change to get the referrals from our hospitalist staff and also our subspecialists. We also expanded our scope of services. So to expand our census, we started working with our oncology colleagues to develop some specific use cases to take care of oncology patients in hospital at home. We've been working with our surgical colleagues to identify patients that would be ideal candidates for hospital at home level service. We also are developing an outpatient component. So all of our beds since March of 2021 have been technically meeting the criteria of the acute care at home waiver. But we are now working on developing an outpatient component to expand our census and to expand our reach into being able to take patients directly from ambulatory clinics as well as freestanding emergency departments and create unique care strategies and service line approach for our census. One of those is with our oncology colleagues, and we've developed a process by which we're now taking care of patients that are receiving bispecific antibodies and are moving towards doing that for CAR T therapy as well. Those are outpatients, but they are receiving hospital at home level care in a modified fashion that allows us to be able to take care of them. And then I mentioned before that we developed this integrated care at home strategy, and that's really been, I think, the game changer for us. Is that we pulled our hospital at home towards a larger care at home strategy to start to make sure that we're moving our patients along the care continuum. So not just is this acute inpatient level care at home, but what is the appropriate level of care that we can provide for our patients. So the same staff that is in our inpatient hospital at home is manning our outpatient service or outpatient beds at hospital at home, but also then helps to take care and transition patients over into our transition services, ultimately into our more advanced primary care services, and then patients back to their primary care home. Our mobile integrated health program or community paramedicine program supports those patients throughout that journey, as do other strategies such as home health and so forth. So anyway, that's the Atrium experience. We'll be happy to answer any questions later on in the chat. So I appreciate everybody's attention to this.
Hi, everybody. I'm Karen Falkenberg. Very happy to be with you here today and speak about home hospitals' experience with scalability and certainly managing census variability. Next slide. Here's a look at where we are today with Mass General Brigham Home Hospital. We are one unified MGB home hospital service. We are present in supporting 5 hospitals within our network: Mass General, the Brigham and Women's Hospital, Brigham and Women's Faulkner Hospital, Newton Wellesley Hospital, and Salem Hospital. We went live with 3 of those hospitals in the past 6 months. We are currently operating at a 40 bed capacity. 75% of our eligible patients are in our service area. We are currently covering 66 neighborhoods served across Greater Boston, 6 days on average spent in home hospital, 2,400 plus home hospital admissions since January of 2022, and 12,700 plus acute care beds days saved since January 2022. Next slide. Here's a look just at Q1, where we are right now. Our weekly average daily census is growing steadily over the first quarter of the fiscal year. We are on track to reach 60 plus average daily census by the end of the year. And as you can see, our capacity is in green. We were running steady at 33 beds until December of this year, when we increased our capacity to 40. And you can see the trends following along. Our plans for continued growth to achieve the 60 by the end of the year, certainly capacity expansion, increasing our eligible patient populations. There's a lot of work going on there with our medical and surgical colleagues and continuing to drive that census. Next slide. So when we think about census and scalability and growth, certainly we all have our long range targets, but the growth and scale really comes from the everyday operations. And this is the lens that I wanted to bring to the group today, just how much we learn from the operations and really what does that look like. Considerations for scale that we've found through our growth. We needed to really continue to make sure that we adjust our workflows to coincide with our growth. The models that you design for a census of 10, may not support that census of 15 or more. And really having a lens into the operational gaps as you grow. The growth is very incremental, but it really happens, the processes and the foundations to support that growth happen in the everyday operations. And that's something that we pay very close attention to. Key elements in building for scale, certainly developing tools that support visibility into the clinical ops and having models that allow us to be flexible and nimble. We look at it like an umbrella. We want to be able to expand and surge up to meet the demand, test the waters for future scale, and certainly cascade back down without being too top heavy. It's really a continued balance. We found that cross functionality built into the role groups really aids with that. And certainly, a high touch point interdisciplinary communication is invaluable. Next slide. And here's really a look at what baking in that cross functionality allows us to be able to do. I provided a couple of examples. If we look at our physical therapy line of service, certainly they can see patients that are in person, they can see patients that are virtual, but we also have cross functionality for our physical therapists to act as navigators. And the Mass General Brigham model, navigators are really the front door into the program. And oftentimes, when they're meeting with patients, physical therapy is a major component of that. And being able to allow the physical therapist to work in their function of physical therapy and also having that lens to navigate allows us to really be able to support and make appropriate decisions on the front end with our patients. Our medical assistants are new to the home hospital model. We use them in a variety of different ways. They can, flex out and have their own visits with labs and vitals and things within their scope. They can partner with different assets in the team, whether it's providers or physical therapists for support. We can work with them to be a bridge for home health aides when needed. And they can certainly help and are a tremendous resource to us with both administrative and supply chain needs. As you can imagine, spanning over 5 hospitals, there's a lot of moving parts, and our medical assistants are invaluable to this work. Next slide. Charge nurses, again, 5 sites, this is really the nucleus of this work, really facilitating the throughput and, keeping the different teams that are supporting this model, providing them all the resources that they need. Charge nurses, we generally think of those as fixed roles, and we certainly like to keep our charge nurses as fixed roles, but in order to be nimble to support the needs of the team, we need to sometimes flex them out as an extra nurse when needed. We can flex them out as educators and clinical subject matter experts if somebody is needing extra support in the field. Certainly, if we are to flex out our charge nurse for any particular reason, we can't leave that spot unattended because there's so much that goes on with that role. So we have cross functionality that are built into our MGB virtual nursing that can swing in and kind of take over those roles that allow us to flex our charges in and out. Our field team is composed of mobile integrated health and nursing, and they're one team. And being able to work with them and toggle between the skill sets of both have been invaluable to us. They are educated under one umbrella. They are very much part of one particular team. Our APP provider group is working within a new model that's been really successful for them, with a mixed modality model to be able to see patients that they've recently been able to increase their ability to see 8 to 9 patients a day by mixing in virtual visits without increasing their staffing. Next slide. And high touch communication model. So certainly in a model like this, communication is key because this is where the learning is happening. So if you can take a look at this slide and see all these huddles, I'm sure you're thinking, well, how does anybody get anything done? Everybody is not really at every huddle, but you can see that it is a very high touch communication model where there's bi-directional communication that's so important. Next slide. Benefits that we have from that high touch communication model is really that bi-directional, like I mentioned, real time, ability to provide unified messaging, to hear unified messaging. And that is where the essence of the scale comes in, because we can twist and toggle our models and adapt to meet the challenges that maybe we didn't know about the day before. And we've found that to be very successful. Next slide. And here are some tools that we use to optimize the work that we do. On the left, you'll see that is essentially what we call a capacity calculator. It helps us to be able to know who is where and distribute visits evenly amongst the team, based on skill set. On the right, you'll see 2 maps where that is basically Zoll. MIH has used Zoll for years to be able to work with their teams and track where their visits are. We now have almost 50% of nursing loaded into Zoll. This provides an incredible layer of safety for our team to know that they're connected and we know where they are. And it also allows us to extrapolate a great amount of data to be able to, again, take that back, scale, and manage our census variability. Where are we moving our parts around to be able to meet the demand in a day? Next slide. And we are part of a much larger team. So that is a look at the frontline team, but certainly many other components to keep our model on its tracks, as you see here. Look forward to questions. Thank you so much.
All right. Well, thank you first and foremost for having me. I'm on the stage with giants here and some very well established programs with very, very high volumes. And I wanted to give you some idea of what we've done at St. Luke's, and we're about 18 months old. And you go ahead and advance the slide. And I was mentioning to John actually when we were uploading slides over the weekend that I owe a debt of gratitude to the Hospital in Your Home users group. When I was first asked about being the medical director of our Hospital in Your Home, I'd never heard of Hospital in Your Home, knew nothing about it, and I Googled Hospital in Your Home and came across this webinar series and ended up watching a handful of them. And so I don't think I'd be here without the Hospital in Your Home users group. At the same token, I think I had a lot more hair and I was a little bit taller and a little bit better mental health before that. So both a double-edged sword. But for the most part, it's been a phenomenal experience. And you go ahead and advance a couple slides. Perfect. And I stole this for Harlan Krumholtz. I like this, but what sold me on the Hospital in Your Home is, we need to break this status quo of brick and mortar hospitalizations where, we wheel the patient in, they lay in bed for 4 days and get up lucky once per day. Then we ship them out, and they're out of the hospital 31 days. We high five and call it a win. And if they're back in 29 days, we call it a loss. And There's certainly a better healthcare model, and I think hospital in your home, at least in my situation, was the fastest way I could be a part of that change. You can go to the next slide. And so 30,000 foot view of our program. We are about 18 months old. We started July 2022. Next month, we should have our 900th admission. I think we're going to hit 880 today or tomorrow. Interestingly, and I'll touch on this, we had a point in time where we were actually doing 50% from the ER and 50% from the floor. Currently this month, we're gonna be more like 15% from the floor. And I'll touch on this. The biggest reason for that is our paramedic capacity is significantly lower. And likewise, our paramedics doing the transport is not an option currently. So it really hampers us with ED admissions. Our patients that are coming from the floor, though, on average are spending 12 hours in the brick and mortar hospital. So if people were admitted, the evening or overnight, we identify them the next morning and get them home. I think our January census is going to be somewhere in the 9.2 to 9.3 range. We hit 15 at one time, and that multiple couriers to coordinators to physical therapists to RNs started running a little bit ragged at 15. Our average length of stay also been interesting. It's our lowest month ever is going to be this January is going to be 3.0. But again, I think that has a little bit to do with we're not taking the patients out of the ER, so they're spending one night in the hospital, then 3 days with us. One about us is we are exclusively Medicare and Medicare Advantage, and the last of my hair is probably going to go to arguing with Medicare Advantage about inpatient versus observation status. We are starting with some commercial payers later this year, which I think will be exciting to have a different payer mix. And you can go to the next slide. And overall, and Trini noted some of my biases. I think part of this might be my bias, but also I think these congestive heart failure patients are the absolute ideal hospital in your home patients. And I said I really hope 10 years from now we look back and think it was crazy that we put these 80 and 90-year-old patients in a dark hospital room just to give them Lasix twice a day and just check their potassiums on a daily basis. So we're about 40% congestive heart failure, about 33% some sort of respiratory infection. For December, January, that's going to be higher. And then some kind of resistant organism for about 10%, then a random smattering from the others. You can go to the next slide. And so, yeah, the challenges are many. I think it's Edison that said, I haven't failed. I can just tell you 10,000 things that don't work. And I'm not quite to 10,000, but I could give you, if we have more time, quite a few. So one big challenge with the ED, it's very frequent that, I hear, 30 patients are boarded in the ED, go take them out of the hospital in your home. Well, this is one of the problems. Our Medicare only model, if 100 walk in that ED, within just having Medicare and living within 25 miles, that gets that number down to about 33 for us, or I should say the ER is going to admit 33. Then of those 33 that got admitted, 35% are Medicare and live within 25 miles, around to 12. Then we don't take, SNF patients or rehab patients. We can take a couple of assisted livings. I wish we could take a lot more assisted livings. And then, the big inpatient versus ob status. And, some of these Medicare Advantage plans, like the narrow range of sick enough to make inpatient status, but not so sick that, the hospitalist thinks they're too sick for hospital in your home is very, very hard to thread that needle. Fortunately, we've gotten a little more, we tried to do a zero tolerance observation policy early on. And thank God we've lightened up on that a bit, because it's hard to say on day zero. A lot of these patients will end up as obs or inpatient. And then, of course, those 7, half are going to need a procedure, dialysis, et cetera. And I'm glad Dr. Davis mentioned it. We have 4 metro hospitals. I'll show you in a second. We do have very different cultures at each hospital. And there is a high variability I have a list of all of our kind of referring both hospitalists and ER doctors, and it's a very good bell curve. I have some hospitalists that refer 1 per week, and I have some that refer 1 per year, and most are in the middle somewhere. But so of that, about 1 ends up in the hospital in your home. And you can go to the next slide. It's like Karen was touching on how to avoid You can go to the next slide. Dips in the census, and boy, it's a challenge. And so we just looked at this because our census dips most weekends, as hospital census does. And so to orient you, the orange is how many patients hospital in your home is admitting, and then these are to the hundredth. But so this 1.3 is 130 patients that overall hospital admitted, and then the 4.4 is 440 patients visited the ER. But so as you can see, a day where 440 go through the ER, 130 get admitted, we admit 2.2. The busiest days of the week, Wednesday, Thursday, admit 150, 160. We're admitting, closer to 3 patients. But then the weekend, they go from admitting 150, 160 to 80. And likewise, we go from admitting 3 to 1.6. So it follows that when the ER is busy and when the hospital's admitted a lot of patients, we admit a lot of patients. And when they're not, they're not. I said we need to, open up some high-risk heart failure clinics on Saturdays. I don't think my partners would be very excited about staffing that clinic, but we're trying to find a source to stabilize the census over the weekend. But a lot of it, I think, is just the general hospital flow and logistics. You can go to the next slide. And then this is a big challenge for us. We're talking to Trini's got challenges with traffic, but so we have 4 metro hospitals. I don't know how familiar you are with Kansas City. It's a good town, very good football team. Taylor Swift's here every other week. You should all come visit. We'll take you out for a good barbecue. But we have an enormous geographic area in the KC Metro. So we have 4 metro hospitals. And so to give you an idea, to this northwest is Leavenworth. That's the prison's probably what they're most famous for. And then our southeast is Pleasant Hill, Kingsville. It's 100 miles driving across there. If Trini drives 100 miles, I mean, she's in past Poughkeepsie, New York, probably. So, to give you an idea, so some people are like, why do you need 4 nurse practitioners? And because, the geographic area is immense. The other big challenge, if there's any big CMS policymakers, is our actual brick and mortar standard of care at a lot of these hospitals is the patients get a virtual H&P in the ER. And then within 12 or 18 hours, they get the physical H&P when they're on the floor. But of course, we cannot do that in hospital in your home. So it's a little bit ironic that in the brick and mortar hospital, they get a virtual H&P, but in the virtual hospital in your home, they must have an in-person H&P. So that's also part of the reason we need these nurse practitioners, boots on the ground. You can go to is just to touch people in these ERs and admit them. And you can go to the next slide. And then one of my hospitalists is actually a businessman / hospitalist, and he had me read this book called The Goal by Goldratt is the last name. I guess it's MBA, MHAs. A lot of you guys have probably seen this before. But it's basically talking about large factory manufacturing. Honest to God, that's where I think the hospital in your home ends up. So, I need the APPs to identify the patients and do the in-person H&P. And I need paramedics to see them in the field. I need RNs to take care of them in the field. And there's a bunch of micro points in the chain too. And Karen mentioned physical therapy, service coordinators, couriers. You can go to my next slide. But the idea with this theory of constraints is that you have to identify the weakest link and then attack it. And you can staff up there. So this is the iterations we've gone through. So when we first started out, we found very quickly we had 1 nurse alone at night, which boy was a little bit harrowing for myself included, seeing what they were doing, trying to take care of 5 or 6 patients. But so we were constrained by nursing. So the first thing we addressed was nursing. So we got to 2 nurses at day, 2 nurses at night. We thought we could comfortably handle a census of 10. And then the limitation was APPs, and the APPs are a little bit of a hybrid. So they both help get patients in by identifying them in the ER, doing the H&P in the ER. They also do some of our field visits. They're also the one where it takes the longest time for us to hire and onboard. So the next goal was to staff up the APPs. And we got the APPs up to 3 per day. Simultaneously, we got our paramedics up to 7 per day, then 3 RNs a day, 2 at night. So we were in fairly good shape. We could handle a census of 15, and we flirted with 15 a couple of occasions. And then we had a turnover in our contracted paramedic company. So we went from 7 paramedics, in November to 3 or 4 in January. And then we also had on board our 4th APP. But the overall kind of strategy and gist is that you focus on that single weakest link, because you can I think, spend hours a day on Zoom trying to address every single small thing in the supply chain in this case. And so in this case, I think our focus is solely on how to get back our paramedics back up to hopefully 6 or 7, and ideally having them do our transport, because that's really the way we used to admit 50% of our patients from the emergency room. But I see lots of questions, so I'll go on to the Q&A portion.
Excellent.
Great. Well, thank you so much for our panelists for delivering really insightful and productive conversations here. We see a lot of questions in here, and we probably will not have time for all of the questions, but I'm going to select a few, and panelists who are or others who would like to answer this, please, let us know as well. There was one question they want to know we want to ask, what is the top patient population that when you expand, you should consider because it would create the highest system impact?
I can take that
say
one if you want. Yeah.
I would say for us, it's really been heart failure has been the number one diagnosed, number one patient population. It's our number one reason for readmission across all of our facilities. And so I think really engaging the cardiology team, and I'd put that in one of the answers in the chat, engaging our cardiology team as well as our hospitalist group, and showing them that we can provide the appropriate levels of care, and then provide a soft landing for the patient once they're discharged from hospital at home, and show that we can improve readmission rates for heart failure. So really going after that. But I would also encourage, it's really looking at acuity rather than diagnosis. I think if we really put ourselves into a pigeonhole of, well, we're going to focus on heart failure or COPD or whatnot, I think you may get a short-term bump, but you think long-term will limit your growth. I think you go for the acuity level of the patient rather than the specific diagnosis. But if I were to aim at one, I would say heart failure right now.
Yep, I was gonna say 100% agree, and you can get me on a Zoom if you want, but these patients don't need to be on a Lasix strip. They can all get twice a day IV Lasix. They do not need telemetry. You're checking the electrolytes every day. But yeah, I am biased, but I agree with Dr. Davis wholeheartedly. And our Medicare heart failure readmission rate is 21%, and our hospital in your home heart failure readmission rate is 7%. And I think it's multifactorial for those reasons, but agree 100%.
That's great. And just related to that, Dr. Davis, you mentioned other population of patients that you are taking into your hospital or working to take into your hospital, including oncology and transplant as well. What do you think about those as the value added to the system?
I mean, these are patients that end up spending long periods of time in the hospital, and a lot of that's sort of like low value time, right? We're looking for complications. And I think what we found is in certain disease states, and again, oncology is that's a tough provider population to move in the direction of letting go of the control of the patient a little bit. I think cardiologists were a little bit more like to say, yeah, take my heart failure patient, I'm ready to go. But literally, I think if we can show that we can take those patients and put them in an environment where we are continuously monitoring the patient's vital signs, or very closely monitoring the patient's vital signs, and escalate the patients very quickly and have a very solid escalation plan for if a patient has an issue, the first signs of cytokine release syndrome with CAR T therapy, that we can get them the care they need rapidly, you start to build that trust. And I think that it's all about showing that you can do it. Start small with those kinds of patients, with that population, and then show the most engaged oncologists or the most engaged surgeons, because that's another group, that we can take care of these patients and do it in a safe fashion.
Great. And related to that, to the question to all of you three, is that how do you create culture change? Because you talk about very resistant or less enthusiastic groups of doctors, cardiologists, not so much, but oncologists perhaps, or transplant docs. What can you share some strategies?
I think for us, it's relationship building, certainly, and presence. There's with the MGB team, there's an incredible amount of relationship building that goes on across our hospital system and strong partnerships. And certainly that has been very helpful for us. We have a very large growing model of surgery that's expanding, quite a bit this year, and the surgical partnership has been incredible, and we see that with other services as well. But it's a lot of groundwork, and it's being not just being in there to cultivate the relationships, but partnering on through throughout the build of the operations themselves. I would say that it would be the relationship building.
Great. Other question. What do you think CMS would do? Do you have a crystal ball to ask to let us know what do you think CMS would do comes the end of 2024?
I think that without a doubt, the hospital at home strategy is going to continue. Now, whether it continues with a full DRG or not, that's going to be, I think, remain to be seen. I think there's also some discussions that need to happen with CMS around what are the appropriate conditions of participation that we're going to require in a hospital home setting or not require in a hospital home setting that we do require in a brick and mortar facility. So looking at the crystal ball and the way Congress seems to do things, they'll probably do another extension. I doubt there's going to be a permanent fix, but I would say that most likely we will have some extension and look diving deeper into results and so forth. So.
Thank you. And I don't know if Dr. Bruce Leff or John or anyone else will be able to comment on that. But I'm hopeful, and I think that most likely, and also probably for the benefit of our model at this moment, to have a flexibility to craft the model that we want as well before some permanency exists.
Mm-hmm.
And then perhaps one last question, and I find this very interesting, is that when it comes to scaling, someone said is that it's easy to achieve a census of 40, 50, 60 from 10, 11 hospitals. That means is that you get a few patients from each of the hospital, less impressive when you think it in that context. So should we think about achieving a census, not achieving a certain absolute census per se, but rather using other ways to measure success, such as bed capacity or bed days saved? So maybe 10, 15, 20% of inpatient bed days saved. And so what recommendations do you have, what guidance do you have for hospitals that are not as large as yours here to achieve to be at a census that high of 15 or 20% of?
I agree completely. Obviously, when you come across 10 or 11 facilities, 60 patients is a much smaller percentage. Of course, it's across a much larger geography as well, so it comes with its own challenges, right? 100 miles east-west, 60 miles north-south. But to get to 200, you got to go through 60, right? So I think that to get to that higher number, you've got to be able to build that infrastructure and all of the what's required to take care of those patients that are going to get you to 10% or 15% of the census. So completely agree. I think we are looking at a percentage number as well, rather than just an average daily census. But again, as we mentioned, there's culture changes in different hospitals, different facilities. You have an academic facility, which is a lot harder to pull patients out of. And you have rural facilities where it's a lot easier to pull patients out of because patients, they just don't have the resources to travel to the hospital as much. So I think you have to look at it not just by the numbers, but by what the geography and what the environment it looks like for your particular health system.
I think so too. I would agree with that. And I think that when we look at scalability, even if my own time within Mass General Brigham, having expanded across in this time, the footprint for the scale is the same with the one hospital that you'll use that footprint as you move into another. and it's really like a completely different place. So you're really starting all over again. It's not like it's a one size fits all as you go. Even though there's 5 hospitals that we have under one system, they're very distinct amongst themselves, and there's a lot of individualization that goes with all of that. So, um, I totally agree, and I also agree that looking at it as far as average daily census may not be the only marker for success.
Thank you. Thank you for that. Um, I'm just going to summarize. There's a lot of very helpful comments and data have been discussed. I want to summarize a few learning points that from all of you here is that to expand the strategy for expand, Dr. Davis, you talk about employing an integrated home health strategy where you move patients along the care continuum to allow shared resources and flexible staffing. That has been helpful. You expand to specialized populations, oncology, transplant, also expand to an outpatient component so you could transition patients from clinic and ED easily as well. Karen, you talk about cross-functionality training, cross-role training for the group so that they can expand to meet the demands when the surge period comes. And Michael, you talk about adjusting or changing, adapting quickly to your needs as well. So I think these are all very important lessons for all of us. And so thank you so much, our panelists, for having for discussing your experiences and learning with us. Thank you.
And thank you, Trini, for ably guiding us through the webinar today. And thanks again to our 3 panelists and the stories of growth and progress and indeed success around hospital and home. We appreciate your time and your energy and your work on all of your programs and in support of the Hospital Home Users Group as well. Just a couple of reminders. This is the QR code and the contact information for the caregiver experience study that we are recruiting for, and we're hoping program leaders will get in touch with us and talk to us more about their expertise and experience with caregivers. Next slide. I want to again remind folks that the Hospital Home Users Group has now 23 webinars as part of its series. As Dr. Nassif mentioned, a great learning opportunity. And again, this webinar and the slides will be up on that site in the next week. Next slide, please. And just to remind folks on the next slide, there is the Hospital Home Users Group can be found at hahusersgroup.org. You can find our Technical Assistance Center there. There's a featured centered resource on the annotated CMS waiver if you are just getting started on your scale journey. But again, lots of other resources, research, and other practical, operational, and policy strategy kinds of resources that you can find on the website. And finally, on the last slide, we want to thank our sponsors, the John A. Hartford Foundation and the American Academy of Home Care Medicine. Again, we appreciate their support, their generous support for our work and for this webinar series. And we appreciate all of you for joining us this afternoon, and wish you all Godspeed and certainly great success in building and scaling your hospital home programs in the future.